spinal muscular atrophy communities and stakeholders among three countries, which are Pakistan, India, and Malaysia. And we are so lucky that today we have representatives from Indonesia. This is a platform for us to share information and learn from others' experience to move forward to build a better system of management of SMA communities, especially in terms of the opportunities and medical accessibilities for the patient. We hope in the near future this relationship and networking will be extended, strengthened, more effective, and advanced until our vision to bring a cure to all SMA babies, toddlers, teenagers, adults, a fruitful reality, inshallah. Okay, before we start, allow me to convey some housekeeping, soft reminder to all participants. Kindly put your microphone into a mute mode to avoid any background noise during this session. And the speaker will present their presentation about 25 minutes each. And the Q&A session will be after the end of our last speaker presentation. The participant can write the relevant question in the chat box, and we will read it during the Q&A session. Thank you. Ladies and gentlemen, to begin with, I'm honored to introduce our first speaker, the Honorable Professor Dr. Zabidi Azhar Muhammad Hussein, the Pro Vice Chancellor in Academic of International Medical University, IMU Malaysia, a medical professor with specialization in pediatric neurology and medical education, a council member of the Malaysian Medical Council, and also a um, medical advisor of SMA Malaysia. Today, we are so lucky to have him who will share his experience, and his presentation title is Do's and Don'ts when communicating with SMA patients. Please welcome Professor Dr. Zabidi Azhar Muhammad Hussein. The floor is yours.
Thank you very much, Fura. Thank you very much for the kind introduction. I'm not going to talk specifically regarding SMA today because I think there are better people who are much better able to do that. The likes of Prof. Go and Prof. Atif, they will be giving the scientific approach to this particular condition. But what I'm going to do today, Fura, can you tell me, are most of our participants doctors or are they?
Several number of doctors.
Yeah, because I see that there are 12 participants on my screen, but I think we have more than that, huh?
Yeah. They are about to log.
About to log in. Okay, that's
Prof,
fine.
Prof, just want to add,
Yes.
majority of them are basically undergraduate, but they are from medicine. Majority of them are from medicine,
Okay.
and they are undergraduate. Beside, we have few people who are from SMA, Pakistan, SMA, Malaysia, other people who are also basically related with clinical background.
Okay. That is good. That is good because often from my years of doing medicine, I find that while doctors are very good with the scientific medical treatment and pathophysiology and so forth, sometimes we need a bit more help when it comes to communicating what we know to our patients. So I think it would be very relevant to address this issue. If any of you have ever read a journal called Oncologist, published in the year 2000, about 10 years ago, a group of scientists and clinicians led by Bale, B-A-I-L-E, and Bale, Buckman, Renzi, Glober, and so forth. They produce a 6-step protocol to communicate bad news to patients. And this 6-step protocol is called SPIKE. The acronym is SPIKE. And it was published in the like I said, in the Oncologist Journal. And this has been used extensively. This acronym SPIKE has been used extensively whenever whenever we doctors wish to communicate, especially bringing in news which are not so good to patients. But this morning I got an idea. I think spike sounds rather painful. And if you use the acronym SPIKE to bring bad news, I think it hurts, it probably hurts more. So what I've done early this morning, an idea came to my mind of using an acronym called SPIKELESS. SPIKELESS, SPIKELESS. And I think the term SPIKELESS should not make it painful. Hi, Anthony.
Hey,
Good to
Anthony.
see you. All right, Anthony, come in. Yeah. So basically, what I'm going to do is to suggest to you a simple acronym, a simple way of trying to communicate with patients, especially when you are about to bring them news which are not so good, and especially news regarding this particular disease called SMA. And I do not have a PowerPoint here, but it's the acronym is SPIKELESS. All right. So in a simple manner, whenever doctors wish to speak to doctors and bring bad news to them, the setting must be right. So the first S is for setting. The setting must be right. You must not be in a rush, because if you are in a rush, then the whole idea about communication will break down. Okay, rushing. The setting must be ideal in such a way that the patient is comfortable. The patient is comfortable and willing to hear, and patient will probably have more than 1 hour to listen to the communication between you and them. And the setting must also be in such a way that it is very conducive. It is very conducive for that particular purpose. And again, that meets the S component of the setting. I'm just trying to remind myself here the various component. Where is it now? It's been written somewhere. Okay. The other component is apart from the right setting. Of course, the setting must not be noisy. The patient must not be in pain. The patient must be comfortable. All right. And the next is P. P, you must have the right personnel there. If the patient wishes to bring a partner, for example, the patient wishes to bring another person to join the discussion, a close friend or close relative or husband, then you should allow that to happen. And you must make sure that the setting is enough and there is enough room for that particular conversation to take place. So P is for personnel. I and K, I'm combining together for insight and knowledge. You must be aware that you must also make sure that whenever patients are given a certain diagnosis, for example, chances are they will normally Google it, all right? And you know what happens when you Google SMA. From Googling SMA will bring you all the dreadful stories about this particular disease. So you must explain the insight. What do they know already about this particular disease? That you must try to understand the prior knowledge. Yeah? And the prior knowledge must be listened to. You must listen to them, and do not interrupt them, and let them explain that insight of what they know already, or what they know from other doctors who may have a lesser communication skills than you. And a K, K is for knowledge. Like I said, the insight is combined with knowledge. And I think the knowledge of what they have, a knowledge of SMA in this particular example, must be appropriate to the level. Sometimes we tend to speak to a fellow doctor who has SMA like we speak with a common person. You see? So we really have to understand the level and speak at the right and appropriate level. That means that you will have to ask the patient's background in the beginning. What does he do? What does he do? What do the parents do? Are the parents doctors? Are the parents lawyers, and so forth? Because you really have to fine tune and level your communication according to their understanding. because otherwise I often, when I don't declare myself as a doctor and I go to the outpatient clinic without declaring myself a doctor, I can see young doctors speaking to me like I'm a fool, so I think you really have to make sure who you're talking to, and that means that some of the knowledge may not be correct, because they may Google it, they may know the knowledge from books and from reading and so on, but leave it to them to explain what their what the understanding is in the beginning. Okay, so we've gone through the setting, we've gone through adding another person coming into the scene. We went through the insight and how much he knows about the particular problem, about SMA in particular, and what prior knowledge he has for that disease. Next come a very important component, which is the E component. E is very, very important, because if you miss out E, and to cover E, emotional and empathy and so on, you really, really, really have to have a big skill called the listening skill. And big ears like an elephant and a small mouth, all right? And use your senses to feel the emotion exuding from the patient. Very, very important. I always like to use the analogy of an elephant, because elephant is not only my favorite animal, but I feel elephant is so good. Elephant can tell when an earthquake is coming, because they have sensors in their legs, so they keep quiet. Even by them being quiet, they can sense something is coming out. They have big ears and listen to what you're telling them, and they do not rush in and trumpet and making noise all the time. So this is a very, very good skill for a doctor to have. Listen, 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 absorb the emotional nuances from the patient, and leave them to cry, leave them gaps to cry, and so forth. So this is very important on the emotional component. Now L, I put L as language, because I think we really have to make sure that the language that you speak is the same language that the patient can understand. All right, very, very important. Now that is why preferably you get someone who speaks the language that the patient speaks. Now let me just tell you a brief story on this. I had to break a bad news to a couple, a young couple, who were Buddhists. A young couple. I still remember. I will never forget this scenario. As I walk into the room, the child, who's an 18-month-old girl, it was on ventilator, and I was asked to interpret the EEG of that girl. All right. So I did the interpretation. I look at the EEG, and clearly that little girl has passed away. Okay. So my task was to come into the room and break that dreadful news to the young parents. And when I walked into the room, I saw the mother sitting on the bed, caressing the hair of that girl, and I saw the husband, the father, sitting in the far corner with his hips down. So what do I do to break this dreadful news? Do I say that, sorry, your daughter has died? What will be the impact of them? Now, then a thought came through. A thought came through me. I was lucky, because when I was young, I used to live near a neighbor who was a Buddhist. And this couple were from were Buddhists. You see, they're from Thailand. So a thought came across my mind, and I feel that I shouldn't be telling them this. But I would probably have to call somebody else to do the thing. And when I was young in that village, a monk who wears the yellow robe, in the Buddhist language in my place was called Tok Raja. All right. So the dialect for a monk in my place in Pasir Mas at that time was Tok Raja. So a thought came across my mind, and I said, "Can I call a Tok Raja in for you?" So the mother immediately looked up to me and said, "Can we do that, doctor?" You see, so clearly, if I was the one to break that news to them, it would be devastating, because I don't know their language. All right, I don't know what kind of a soft landing they will have in telling them that bad news. So I offered them a monk who in their language is Toraja, and immediately they took it up. And I did not break that news to the parents, but I left it to the monk to do it. And clearly, I left the room, and everything was okay. And when I came on that happened on a Friday, but when I came on Monday, the parents left a note to me and said that please thank that doctor for offering the monk to break the news. All right. So I think there are certain ways that you can do it without barging and telling them and so on. So I think you need to find other ways, other languages, to produce a softer landing. And I think that will need experience. You will need to consult with your seniors. You will need to talk to your colleagues and so on. Because
Yes.
breaking a news of SMA is not small, right? It is a lifelong problem. So you really have to be sure that what you're saying is actually something which has a very, very soft landing on the parents. Now, LESS. E I think in your discussion with the parents, with who has a child with SMA, or in discussing to breaking the news, communicating with the child yourself, for example, you need to be aware of the economic condition. All right, uh, as you know, the price. Safura will know how much it costs, to treat SMA now. I mean, what is it, Safura? 12 million, isn't it? For one infusion. Yeah, can hear you.
Yes, Prof.
Can hear you.
Around 2 million. Yeah, correct.
Yeah, 2 million, isn't it? Or 12 million, I can't remember. But it's very, very expensive. It's very, very expensive. So I think we need to know broadly about their occupation, about the support they're likely to have, and so forth. Because unless you are aware of that, your discussion with them may not be very relevant. All right. And so ES is for economic and social. Very, very important to understand the social background, the family history, and for medical students, you really, really need to have that information upfront. Appreciate and get yourself immersed in the socio-economic capabilities and so on. And the last S is a summary. And basically, what you do after your conversation with them, you would say that, okay, I've done with my bit now. Can I just check whether you understand what is being spoken about? So you basically give them a chance to relate their understanding. So they will say to you that, okay, it looks like this is the problem, the condition. So you listen to them, and then you make a summary of the condition. So it is not only relevant for patients with SMA, it's relevant for anyone that you have to break a bad news, you have to break a big event, you have to break a very devastating problem. And I find today that the acronym of spikeless, and when it is spikeless, it doesn't hurt anymore. All right. When it's spike, it hurts. If it is a spikeless, it does not hurt anymore. I think that is all that I have to say. I will really need to be updated from Prof. Teguh, from Prof. Atif, and so on, to be updated on the latest of SMA. But that is my contribution for morning's webinar. Thank you very much for listening.
Thank you very much, Prof. Dr. Zabidi Azhar, for your important information and insight in dealing with SMA patient and parents. Fightless is a good acronym. Not only we convey our sympathy, more empathy.
Yeah.
To anyone who would like to raise a question, or maybe we wait until the Q&A session.
Prof. Anthony is there, so probably we can think about publishing this backlist.
Still with us, Prof. Anthony?
Yes, sorry, I was muted. Sorry. Yeah, it's interesting. Normally we do use spikes, but spikeless sounds, you said, it does give the soft landing, doesn't pierce too much. Yeah, maybe we
Exactly.
could.
Yes. Yes.
Okay. Okay. Shall we move to the next speaker? Next, I'm honored to introduce our second speaker, Dr. Dian Kesuma Pramudia. He's a senior lecturer and vice head in the Graduate School of Clinical Medicine, Science, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. He is also working as a pediatrician in the Pediatric Neurologist Division of Department of Child Health, also in Dr. Sedijo General Hospital. Besides that, he is an expert member of the SMA Diagnostic and Therapeutic Development Team of Genetic Working Group Faculty of Medicine in Universitas Gadjah Mada. He is the co-founder of the Indonesian SMA community from 2017 until present. Ladies and gentlemen, please welcome Dr. Dian Kesuma Pramudia, and his presentation title is Recent Updates on Spinal Muscular Atrophy Assessed from Community Approach. Yes, welcome, Dr. Dian.
Thank you, Ms. Safura, Honorable Professor Sabidi Hussein, Professor Anthony Cummins, Professor Atif, Prof. Teguh. Could you hear my voice, everybody?
Yes, very good.
Yes.
Very clear. Very clear. Very clear.
Thank you. Assalamualaikum warahmatullahi wabarakatuh. So, good morning for all participants, ladies and gentlemen. Thank you very much. It has been an honor for me to be invited to give or to share some insights from Indonesia. And thank you very much for your nice introduction, Ms. Safura. So I will introduce her back. So the one that I'm impressed so much is Ms. Safura here is a PhD student under Professor Teguh, right? And then she is now is also SMA patient type 2. So I'm most impressed with her quality of life. So that is why maybe later I will invite her back also to give some talk to our community in Indonesia to give inspiration to our patients. Okay, so
Thank you.
so allow me to wait for a moment. Allow me to share some of the. Oh, wait. This is allow me to share one of my presentation, but the share screen is not working well. Okay, wait a second. Can you see? Oh, can you see the screen? Oh, sorry. Okay, can you see the screen now?
Yes, yes, we can see it.
Okay. Okay, so could you, everybody, could see my slides here? Hello? Oh, sorry. Something's wrong is happening here. Moment. Okay, wait. Okay, I hope everybody could see my slides. Is it okay now? Because I cannot monitor the slides due to some problems with the entire screen.
Yes, Dr. Dian, it's
Wait,
already on
wait.
screen.
Wait for a while because this is something wrong with the. Application window. Okay, you can see our slide. So allow me to start my sharing. So it is about the recent updates on the spinal muscular atrophy. So the community approach. We would like to share our experience from Indonesia actually. So first of all, I would like to disclose there is no conflict of interest during my presentation. So I receive anything from any medicines that I will present here. So, and the next, maybe first of all, we'd like to introduce you our community. So here we are, Indonesian SMA community, co-founded with four of us. So I'm just one of the co-founder. Mrs. Sylvia Sumargi, which also attending this meeting, is also one of the co-founder, along with the two other founder. So our secretariat is located in Bandung. So you can see all the slides, right? Okay. So here, Bandung is located on Java. You can see the island. Maybe for you, yes,
I cannot see the slides.
you can see the slides. Okay, okay. Wait. I changed to entire screen then. Okay. Now you can see the slides.
Yes.
Okay. So let me back a little bit. So this is our Indonesian SMA community, founded on 2017. We have our own specific color, yellow. So here we found this community on December 2017 together with most of the SMA patients located in West Java province. So most of our patients come from West Java. We still do not know about any other province from Indonesia. However, I suppose that it might be much more again. So this is my picture 3 years ago. I don't know whether I'm now still look the same, but thank you, Prof. Abidin, to mention that I'm still look the same actually. So, and how about the SMA laboratory centers? We introduced actually in Indonesia with already with all of the provinces, 37 provinces, we only have 2 central SMA laboratory. First is in the Eichmann Institute in Jakarta, which perform some examination based on the standard procedure. And the second is our university on UGM. We usually perform on the Radio Putro and Tahir building. Here our lab located. So, however, you must know that this is our coverage throughout the nation. So we have 17,000 islands, consists of 6 major islands, and we have to cover all of this province to make a newborn screening. Those all. That is why it's quite challenging task for us as a SMA team in Indonesia to be able to perform like screening and diagnostic. So just a little bit slight insight about what is spinal muscular atrophy. I believe most of you has already been known about this topic. However, let me refresh a little bit. So this is also, I start with a picture of our SMA patients. Here comes one of our most strongest fighter. He is SMA type 2. Names is Hayu. Her name is Hayu, and is type 2, maybe type 1.5, because now she's still surviving until now. She's already 4 or 5 years old and still doing okay, even though she has to live with lots of complications like a contracture and scoliosis. So, and the other team, then the other patients and the other children still thriving well until right now. So just a little bit refreshing that spinal muscular atrophy or SMA is mostly caused by the mutation SM1 gene. And yes, indeed, in Indonesia, is also the incidence is approximately 1 in the 6,000 to 10,000 live births. My current screening predict that the carrier frequency is approximately in a 1 or 1 in the 40 or 41, 5. Frequent, a little bit more frequent compared to the world frequency. So basically, as for the clinical type, we can classify the SMA into type 1, type 2, and type 3, where the type for the as a simpler for type 1 is the patient is unable to sit, but for type 2, the patient is able to sit but unable to walk, but on type 3, patient is able to walk assisted. So as for make it simple like that. So until now, it is quite still difficult to discover patient type 1 patients in our countries. Sometimes we can find several patients already been intubated in ventilator for our several major hospitals. However, they could not survive for long. So we have around 7 patients with 1, and most of them will pass away. And about type 2 and type 3 is the comprise most of our members in Indonesia, and until now they're still striving to live their life better. So just a simple the name of the SMA, who are still eager want to know that SMA is caused by the mutation on the SMN1 gene. SMN1 gene is located on chromosome 5 here, and you can see that the gene is spans for about 20 kilobase pair over 9 exons. And thank goodness, because the gene size is not quite big. Actually, it's not a big deal. It's not a big job for making a diagnosis based on the presence or absence of this SMN1 gene. However, the problem lies to the wide coverage of our country, actually. So if we describe in details about the SMN1 and SMN gene structure, it has already been found actually that SMN1 is not standing alone. We have the copy of the SMN1 gene called as SMN2. However, in SMN2, there is a slight difference in the nucleotide in the exon 7 and position 140, where here nucleotide C is changed into T, resulted in the lack of the SMN functional protein transcribed from the SMN2. So with this knowledge, actually many pharmaceutical companies try to develop lots of drugs which able to modify SMN2 inability to produce functional SMN protein, so that they able to produce more SMN protein compared to the SMN1. So SMN1 in the SMA patient is deleted, so that is why everything is depend on the ability of the SMN2. However, one company Avexis try to insert such a healthy SMN1 using a novel genetic therapy, which is called Zolgensma, which is now also considered as one of the novel treatment. However, how is the status and how the progress until now, I will tell you in the later. So now we try to describe and we try to share about our challenge as a SMA community to access to the diagnostic and to access about to the therapy. And basically, for the molecular diagnosis and SMA, as mentioned by Arnold in the previous publication, we have to be aware we have to suspect SMA if we can find several clinical signs like proximal abdominal weakness or reduced absent reflex, etc., etc. And we in Indonesia also added some additional examination about which are an ENMG, electroneuromyography examination, and the examination of enzyme, muscle enzyme, including creatine kinase and creatine kinase myocardial band. So if we, because of the lack of the genetic examination in our country, so we rely heavily on the clinical approach actually. So by doing such a clinical approach, we able to to make a suspicion to a patient, and then that patient will be consulted to our center, and then after that we can perform the molecular diagnosis. So this is just for confirm for SMN1 deletion type of SMA, including and comprises and SMN1 deletion. However, for non-SMN1 deletion or other non-5q SMA, we still need to look for the further appropriate method actually. So the molecular diagnosis of SMA for the standard protocol, usually now we know we mostly use MLP analysis or multiplex ligand proben amplification provided by Holland here. Singapore and also Eichmann Institute in Indonesia also use such a MLPA method. The principle of this method is to put a to put a probe in a certain location in the SMN1 gene, and then after that we try to read the amplifications, and then if the amplification of the PCR here is not as high as the signal emitted from other gene or other amplifications, so we can conclude that the number of the SMN lower or so. However, the pitfalls, or not the pitfall, I mean the problems of having MLPS analysis is about the cost. It's quite expensive, and the reagent is very exclusive, which means that we could not use our own homemade reagent. So that is why using MLPA in our country is kind of limited. And then this MLPA usually only used in Eichmann Institute in Indonesia. So to overcome such limitations, actually, we try to develop our own feasible molecular diagnosis technique, which only use like a simple RFLP PCR, so restricted fragment length polymorphism, using like a digestion enzyme, so we can diagnose the SMA based only the presence or the absence of the SMN1 exon 7 and then exon 8. The figure will be like this. So this feasible molecular diagnosis technique enable us to fast to diagnose the SMA fast and cheap and more and quite reliable actually. However, the limitation of such a diagnosis is we cannot identify if there is a presence of SMN1. We cannot identify the amount of the copy number of the remaining SMN1, whether it is SMN1 is 2 copy, 3 copy, or only 1 copy, so that we cannot clarify or confirm about the carrier status of the patient. So to overcome that, previously we in our laboratory in Kobe University perform like real-time PCR using cyber green detection in order to clarify about the SMA or SMN carrier status. So here, using this method, we can calculate the copy number of the SMN1 gene or SMN2 genes, so that if we found an SMA patient, we can classify the patients into type 1, type 2, or type 3 based on the amount number of the SMN2 copy number. However, this method found to be also quite difficult to be executed in Indonesia due to the exclusive of the reagent. So such a reagent mostly have to be used side by side with the machines. So previously we used Roche. However, in Indonesia, most of the machines utilizing from Bio-Rad, and then our protocol is kind of unsuitable for the machines. So that is why here, with so many limitations in the giving molecular diagnosis to our community, we try to work together with the community. And here is the work of the Indonesian SMA community in order to coverage all of the patients from the west, from Aceh to the most east, from Papua. So on 2017, we developed and formulate a clinical screening criteria, and then we type it in like a free calendar, and then our community here with Ms. Sylvia Sumargi distribute all of the calendar and the clinical screening criteria to Indonesia, to all over Indonesia, even offline. And we use also online platform to distribute all of them. And then this is the number of the number of the distributed clinical criteria, and then the number of the patients suspected and reported back to us within only 1 year. And then after that, some of them have already been sent after this is like here is like the clinical screening criteria and the flyer from the produced by Indonesian SMA community. After they distribute to all over Indonesia, we also send, then we develop just blood. We send to the doctor or physician who contact us. And after the blood got sent there, and then they send it back to us. And here when we do the extraction analysis and the PCR in our laboratory. So instead of using a very laborious PCR RFLP and also real-time PCR with the previous method, our team also developed a new method to directly able to diagnose SMA based on the number of the, which is now is called the C. Here, our PCR method is also very simple. Docs are banned to see about the deletion of one, but just with the use any kind of, we are able to amplify the specific region of SMN1 here. So, and also differ it from SMN2. So such a COP method with more modified in the primer composition and the primer formula able us also to calculate the copy number of the remaining genes, whether it's the copy number of SMN1 and SMN2. It's already been published, and you can see later in the International Journal of Neonatal Screen. So basically, our challenges in diagnostic and screening is including first is the acknowledgement. So in Indonesia, professional organization like Indonesian Pediatric Association still not still not know well about the SMA, about the incident of SMA in Indonesia. We are still working on making a good SMA registry in our country, and after that making a publication so that we can acknowledge by the professional organization. If the last such acknowledgement has been ruled out by the professional organization, actually it is just an easy way to elaborate the problem to the Ministry of Health. Actually, some of us from Indonesian SMA community has been make like an audience with the staff from the Ministry of Health. However, yeah, until now the feedback is not yet satisfying. So, moreover, in 2020, actually, our work is kind of practically kind of stopped and halted due to this pandemic, so that the increase and the amount of the new patients finding is decreasing a lot due to this pandemic, and because also I have to be placed in the front line to fight such a pandemic, so that is why the progress of the registry itself is also kind of delayed. However, here our research also also try to make a new finding. Here we instead of relying on the PCR, we are now able to find a new biomarker which can be found in the patient's blood. So basically, if we can even calculate, if we able to calculate and determine or maybe calibrate about the amount of the SMN level in the plasma and corresponding to the clinical outcome, so we can classify the type of the SMA based on that. Here we develop a new made a new device which is we call electronic tongue. Here you can see this is one of our product. However, we still in the in the process of calibration right now. So we calibrate the machine so be able to detect the amount of the SMN level and also corresponding biomarker. Here we try to detect what we call is neurofilaments in the plasma, and then we complete the analysis using the of the neural network. So that is how we try to overcome the challenge in the diagnostic and the screening. So now we move on to the last part of my presentation is about the challenge of the implementation of a new drug in Indonesia. So as we know together that therapeutic intervention strategies and SMA needs a multidisciplinary approach, not in medicine, but we also, as Professor Sabidi mentioned, that we also need the consultation for the good communicator, good physiotherapist, good psychologist, and parental support group is also playing a vital role in the successful treatment of SMA patients. So regarding on that one, we also, however, I will not discuss all of the therapeutic intervention strategies, but I've tried to focus on the little bit on the development of the new drug. As we know, Now we are already been informed by the several new drugs which has been approved by the FDA. So one of them is, you know, about the Zolgensma or VXS101, which aim to replace the SMN1 gene. And then other is now is small molecules RG7916, or mostly known as a risdiplam, which is the most the first of the oral treatment approved by FDA. And then it works like a splicing modifier, which means it targets to the SMN2, able to make the splicing correction, able to perform a splicing correction on SMN2, which make SMN2 able to produce more SMN proteins. So we also already have the nusinersen, the one that Professor Sabir has mentioned, with the astronomical price of it. They say that we still need to continue to inject such a medicine for throughout the life. So other medicines has also been being currently developed, and the pipeline of the clinical trial can be looked here. So the one with blue is already been approved by FDA. However, the other with the yellow one is still performing like a clinical, like under the clinical development. So here I'll try to just cover a little bit about the most three of the new novel. However, we try to also to share our experience using already available treatment in Indonesia. So this is the three drugs that I want to share with you, and then how about their progress until now, and how can we access such a treatment actually. So here there are nusinersen, risdiplam, branaplam is for now a little bit halted because of several finding of side effects. The other is Zolgensma, is still also under clinical trial right now. Okay. So how about the feasible strategy of treatment in Indonesia? So here I'll try to classify based on the target. So which are one is SMN1 replacement targeting. Usually now is Zolgensma playing role here. SMN2 targeting for the splicing modifier. Here in Indonesia, the one that we put in the red is using valproic acids and aminoglycosides. And also until now we are still using salbutamol as SMN protein stabilization for patients in Indonesia. While other splicing pattern correction medicine for the SMN2 targeting, like nusinersen and risdiplam, is not yet entered to Indonesia. However, some of the manufacturer is already making approach, and now they are trying to make like a preparation for being able to like a trial in Indonesia, but challenge is still lots of it. So here we try to share a little bit our finding, our using of valproic acids in treating for Indonesian SMA patients. Here we have already published several publications, several manuscripts regarding of the usage of valproic acid here. The mechanism is actually to improve the HDAC inhibitor. So that is why the acetylation level is decreasing, and then the transcription of the gene is improved. So that's the basic mechanism. In fibroblasts, it can be found that it was able to increase the total SMN, the full length or functional SMN protein level. Also, we also find that it also able to increase the SMN protein, but only in the fibroblasts. So it also happened with our project in the salbutamol, where the valproic acids aims to increase the SMN protein level by inhibiting the HDAC by performing like a HDAC inhibitor. However, for the salbutamol, we try to inhibit the degradation of the SMN protein which have been synthesized. So this is our publication is also already been ruled out about the ability for salbutamol to increase the SMN protein. And here also the result of the Western blot, which is showing that the SMN level can be increased in the SMA fibroblasts. However, when we try to treat our patients using combined protocol of physiotherapy, electrical stimulation, and giving salbutamol and PPA, here you can see that most of our patients Blue is the type 1, yellow is the type 2. Here the orange is the type 2, and gray is the type 3, and type 4 is on the yellow ones. So most of our patients, the one which receives salbutamol PPA can be used in the type 1, type 2, and type 3 and type 4. However, the result in the clinical appearance, if we measured using Hammersmith functions of motor scale examination, the increase is not quite significant. Some of the patients mentioned that they feel an increase in their strength and their quality of life. However, for the objective measurement showed not quite different, not quite significant difference in their measurement. Here you can see that SMA type 2, which is non-treated, and the blue one is the treated. There's a slight increase of the HFSME. However, it's not too far, not like so not fulfilling my expectation. For SMA type 3, also the same. So such a modest increase, I believe, until now is quite enough for also, let's say, improving the quality of life of our SMA patients. However, we are still looking forward about the upcoming treatment for the SMA like this one. So nusinersen or Biogen, sorry, I forgot to translate to English. So Biogen works like cheater. So they try to cheat the SMN2 gene transcription by inserting ISSN1 sequence here, so that the transcription is able to improve the amount of the SMN protein here. So because SMN2 gene mostly produces SMN delta 7 or less functional SMN protein, so that is why by using this drug, they're able to produce more and more SMN transcript, resulting full-length SMN protein. However, because it is a splicing modifier, a Biogen needs to be injected annually, and the cost, it's quite astronomical. It has been approved by FDA in 2016, and until now, the clinical trial has already been spread all over the world. And you can see here the result of the trial, including several phases. There's NDR trial, SHINE trial, and most of them showing the improvement of the outcome of the SMA patients. In SMA type 1, SMA type 2, and also pre-symptomatic patients is also showing an improvement. However, just as mentioned before, the patient needs to be injected annually, and it needs to be continued throughout the life. So Zolgensma, produced by Afexis, is now one of the novel treatment, which is already approved by FDA on May 2019. The mechanism, as I explained before, is try to replace the SMN1 gene. And the result of the trial now is still ongoing until now. So phase 1 on CT, and just already the peer-reviewed publication already been can be found. And then they said that there is an increase in the CHOP intent is one of the muscle measurement until now. And then the cutoff point is still 18 months for the treatment. Until now, the report also mentioned that there is an improvement in the outcome of the patient. For the pre-symptomatic patient, so the patient with SMA but still before the beginning of the development of the symptom, Zolgensma also already performed like a clinical study, and this is on the phase 1 in the sprint, and then until now still need to follow up until now. And the last but not least is about the newest one, which has been approved just now in the August, is the risdiplam, the first oral treatment for the spinal muscular atrophy. Actually, the clinical trial also still running. There are a Firefish clinical trial and still open label, and still try to measure how good or how effective these medicines to give improvement to SMA patients. On SMA type 2, also there is a Sunfish trial, which is also still ongoing. So how is the challenge for us as a community to get on such a treatment and trials in Indonesia? So on our experience, basically most of the a company pharmaceuticals or the trials to be able to be executed or launched in certain country, they want to make sure that there is an availability of standardized diagnostic and monitoring facilities, mostly run by academia here or like medical facilities. So if we have such a system, the clinical trial can be executed. So that is now what we are trying to fight and what we are trying to build in Indonesia. We have the diagnostic system, we have the monitoring facilities. However, we still could not reach to all over Indonesia. We still need to think about how we can cover all Indonesian islands from west to the east. About the standard of care of SMA patients is also a challenge for us because not all of the Indonesian physician is well aware with SMA. Actually, we already distributed the document and the protocol for standard of care of SMA patients throughout Indonesia. However, not all of professional organizations willingly to adapt such a standard of care. So they also mentioned about the requirement of having original patients from Indonesia, which is now we have around 96 positive patient confirmed in Indonesia. 96, I believe, yes, 96 out from around 200 of suspect. And then we have to have like a registry, which is now we are trying to build to be able to become the data for then the trial can be executed to Indonesia. And then the next requirement which is need to be done is the publication, of course, which is now we are working on it. And then the last from the list, after we fulfilling all of the requirement for first, and then we can move on to the legislation and bureaucracy by asking for recommendation from the professional organization. And then after that, we can move on to the, like here in Indonesia, we have BPOM, like the Indonesian's FDA, to be able to register such a medicine. And after that, we can approve by the Ministry of Health. So here, our upcoming effort is to be able to early screen all newborn, especially with suspected of having SMA, even in the pre-symptomatic stage. Our new device, which able to measure the SMA protein level just by the drop of a blood using that electronic device, may help us to contribute more about this early screening. And then we try if we able to early screen the patient suspect of having SMA, especially when in the pre-symptomatic stage, we can give them early treatment here so that we can prevent any long-term complications. So Mr. Safura is one of, maybe I believe that one of the good example of a very good combined treatment. And even though she could not consume any medicine, but she could live with how should I say, high quality so that she can pursue her dream. I wish I could provide such a treatment also to my patients in Indonesia. So in summary, basically, even though definite pharmacologic treatment of SMA is still promising, we still need an early diagnostic and holistic integrated management to be able to increase the survivability of SMA patients. Here, our already available treatment, including salbutamol and VPA, might not improve the clinical performance significantly. However, it still help the patients to be able to live their life fully and to be able to make the patient live stronger, even though the objective measurement is not quite good actually. So in order to make the next medicine will be available to our community, inter-institutional collaboration is necessary. So that is why here I feel very honored to be able to know all of you, to get acquainted to Professor Atif, Professor Sabidi, the city, and Dr. Sri Lankani from India. Maybe in the future we can collaborate together to be able to provide the best of the treatment to our SMA patients and their families. Those conclude my presentation. Thank you very much. I'm sorry if I pass a little bit the time. Thank you.
Thank you very much, Dr. Dian Kasuma Pramudia, for your insight and share these very useful resources, develop and improve diagnostic tools, especially utilizing cheap and affordable protocols that makes the genetic diagnosis become easier. I believe especially for the newborn babies, and also the mechanism of the drugs that's available now. Um, we have a question for you, Dr. Dian.
Hi,
It's from Prof. Teguh, is it?
Dr. Go.
Yeah, it's stated here. Uh, could uh, could you elaborate on special precaution for SMA patient during the COVID-19 pandemic? Any case so far?
Ah, thank you, Prof. Go. Yeah, correct. So actually, during this COVID-19 pandemic, I have to shift my focus previously from SMA to this COVID-19 because I was appointed as the chief of the COVID-19 management in my my second hospital. So that is why it's also being my big concern to be able to make sure that our patients in SMA community can live safely. So until now, we already make like several webinars to be to the our SMA community to give them like an education and to give them like information how to avoid getting infected from COVID-19. But thankfully, because of this COVID-19 pandemics, most of our children in SMA community able to, I would say, going to school online. Actually, it is just my assumption. However, I believe that their quality is much more improved because they live only from home, but they can enjoy all of the activities by online. All of the school activities is shifted to online. So that is why most of our, alhamdulillah, until now, there is no case of our SMA patients getting contracted with the COVID-19. All of them are still safe right now. But we also give them some like precautions. Actually, I have the slides here. So the precautions of having the SMA patient will be much more vulnerable because when they going everywhere using their wheelchair, they will be the ones who will get easily to be contaminated by the droplets of the aerosols because if somebody breathe or yell and the droplet of aerosols can fly over 8 meters or 1 and 2 meters. However, for patient with SMA, which is the position usually sitting and lower than any average person, they will get contaminated easily by droplet. So now, until now, our our special precaution is just a simple precaution of having, so let's say Indonesian acronym is Cita Mas Jajar. If I mention Cita means cuci tangan, wash your hands every time you touch something, including touch your online packaging or online shopping package. And then mask means mask. So you always use the mask every time you going anywhere. And then jajar means jaga jarak in Indonesia, or please do the self distancing. So until now, but most of the Indonesians SMA is mostly stay at home. So that is why I believe that is the best and the safest way to avoid being contracted by COVID-19. Thank you.
Thank you, Dr. Dian.
Thank you.
Thank you. Next, we are honored to introduce our third speaker, Ms. Sri Lashmi Nalam. She is the Director and Patient Advocacy from Cure SMA India. We are so lucky today to have her to share with us her experiences as the advocate of a big SMA community support organization in India. Okay, without further ado, please welcome Ms. Sri Lashmi Nalam with her presentation title, Empowerment Through Community Building, SMA in Indian Subcontinent, the subcontinent. Okay, the floor is yours, Ms. Sri Lashmi.
Thank you, Sapura. Can you hear me?
Yes, yes.
Hello and good morning, everyone, all the distinguished guests and all the other audience. I am Sri Lakshmi Nalam from Cure SMA India. And to clear once again, I am not a doctor. I am a parent and a co-founder of the Patient Activity Group. Yes, is my slide visible?
Yes, it's visible.
Okay. I will continue my presentation. My topic for today is empowerment through community building, SMA in Indian subcontinent. We all know that a rare disease is a health condition of low prevalence and affects a small percentage of people, generally between 6 to 8% of the population. And 80% of these are genetic. SMA is one such rare genetic neuromuscular, progressive, and degenerative disease. Due to the low prevalence of the disease, medical expertise is rare and the knowledge is scarce. Relatively common symptoms usually hide the underlying disease, and this leads to misdiagnosis and delayed treatment. This is a disease that robs people of physical strength by affecting the motor nerve cells in the spinal cord, taking away the ability to walk, eat, and breathe. SMA not only affects the person diagnosed, they also impact the caretakers, friends, and families. Compared to today, it was a completely different scenario 22 years back when my son was born. He was a healthy, cheerful child, and all his milestones were normal. Around the age of 1, we found that he couldn't stand and walk independently. After a series of consultations and tests, finally the muscle biopsy confirmed it as spinal muscular atrophy. We were totally shocked and devastated. The big question in front of us, what is SMA? We did not understand the diagnosis very much. The doctor explained that this is a neuromuscular genetic disorder with weak muscles. He also said that he will not be able to walk and he might be having a short lifespan, and physiotherapy is needed to maintain his muscles as long as he lives. Other than this, we did not have any other awareness and the prognosis was completely unknown. We did not know what to expect. In those days, we did not have any Google to search for, nor any community to share our concerns and understand the disease better. And thus, with this limited knowledge, started a lonely journey into the unknown. Raising a child with physical disability is very challenging, as all of you know. The doctor only told us that this is a neuromuscular condition and so muscle weakness will be there, and nothing more than that. But the complications that arise were much beyond our expectations. Every day was a new learning experience with multiple challenges in the following domains: nutrition, respiratory, orthopedic, rehabilitative, emotional, social, etc. At the age of 4, I was advised to put my son on a strict diet with high protein content, low carbs and fats, and no junk food absolutely. And till date, we continue this diet. A child with SMA is generally at a high risk of developing severe respiratory infections because of the weak respiratory muscles, and this leads to frequent colds and coughs. We need to do regular spirometry and other chest physiotherapy exercises to maintain the lung functions. Orthopedic symptoms are the most prominent and include the contractures of the lower and the upper extremities mostly. And we can even see some fine tremor of the fingers. Furthermore, there is a high risk for spontaneous fractures because of the weak bones. My son got fractured for 3 times with the slightest fall. The major problem is scoliosis. This is very common in most of the SMA patients. Scoliosis is the curving of the spine because of the muscles which are not able to support them. The curvature is generally S-shaped and it keeps growing. He was wearing a brace to prevent the scoliosis, but of no use. We were advised to go for a surgery once the Cobb's angle of the spine crosses 60 degrees. And accordingly, we went for a surgery where the spine was fused and two rods placed to support the spine. This helped in a better respiratory function because otherwise the lungs would get compressed and the respiration is compromised. So this was a great savior. Patients with SMA generally have progressive muscle weakness and leads to difficulty in sitting, walking, swallowing, and breathing. Regular physiotherapy is required and you need to do regular exercises to improve the posture, prevent the joint immobility, and slow down the muscle weakness. Stretching and strengthening exercises may help in reducing the spasticity, increase range of motion, and improve the circulation. Most people with SMA also require additional therapy for speech and swallowing difficulties. The emotional toll of living with SMA or caring for a child with SMA is tremendous. In fact, it becomes very normal for parents of children with SMA and adults living with SMA to experience a wide range of unpleasant and distressing emotions such as sadness, anxiety, anger, and frustration on a daily basis. It really requires a very strong willpower and motivation to face the challenges daily and still be in a positive frame of mind. Social stigma is common towards people with disabilities as they are often seen as those who are dependent on charity and pity for assistance. They're also often socially segregated, and it's difficult for the society to appreciate that they can live a normal life like others. It should be realized that they need empathy and not sympathy. This also causes issues with going to the school, traveling using public transport, mobility within academic institutions, attending social gatherings, activities requiring indoor mobility, and leisure activities. Lack of wheelchair accessible environment also creates difficulties in accessibility and accommodation. As time passes, we slowly got to live the new way of life with challenges popping up every day. We observed that my son was having high cognitive skills, and so he should be given a normal schooling. And when we went for the school admissions, it was a real nightmare. Integration in the schools was very difficult. We found that with great convincing and fighting, we could get admission into a school, but integration was very difficult. The students were very friendly and he could mingle very freely with them without any restrictions, but the staff and the management were not so. He was very brilliant in his studies and other extracurricular activities, and he could win awards and rewards for many events in the national and international competitions. He has been certified as Microsoft Certified Solutions Developer at 9 years, and he was the youngest at that time. He received the National Child Award for Exceptional Achievement given by the Indian government. He is an avid quizzer and he has done many more. All these awards slowly changed the attitude of the staff and management towards a compassionate outlook. Facing such hostile environment and physical challenges with mental strength and strong motivation, he went on to complete his education. He has completed his MS in computer science and now works for Microsoft. Drawing from personal experiences and our lonely journey, it illustrated the need to develop effective community support for future children and SMA families affected by SMA. We all go to the doctors regularly, but most of the patients still feel dissatisfied because they don't have the time to clear all their doubts. A person's family and friends may not actually understand the nature or impact of a disease or treatment and so may not provide adequate emotional support. Taking care of a child with spinal muscular atrophy significantly affects several aspects of families' lives, including finances, career choices, social life, and mental health. We desperately feel the need of a resource where the patients can go for more information and increase their awareness. A support group with a common goal is the right solution in such situations. I was lucky to get in touch with a small patient group started by Mrs. Alpna Sharma in India. I immediately joined and was happy to find a new environment exclusively dedicated for the SMA patients. This small group evolved into Cure SMA India with Pan India presence. This group allows us to share our personal experiences, hardships, and frustrations openly and honestly with people who are going through similar challenges. Probably the biggest advantage of the support group is helping and realizing that he or she is not alone, that there are other people who have the same problems and thus reduces the feelings of isolation. This also leads to better understanding of the disease with knowledge sharing and their practical experiences among members, reduces the stress, depression, anxiety, etc., and improves the skills to cope with the other challenges, and thus helps to keep staying motivated. Thus, we can say that a support group among people with similar difficulties helps to bridge the gap between the medical and emotional needs. As we go forward as a patient group, we understand that there is no awareness about SMA in most of the sections of the society. The main objective of the group now is to create more awareness among the different sectors of the society. The families of SMA children have very low awareness and knowledge about SMA. The difficulties of living with SMA actually begin with a long and often arduous process of finding a diagnosis for their child. The psychosocial effects of coping with SMA are substantial and wide ranging, both for the individual living with this condition and the family members affected. From sharing their struggles and fears to discussing various aspects of care and management, the members of the support group become more aware and develop a positive attitude, as this knowledge will help them to understand the effectiveness of proper care and management and attain a better level of functioning in the daily life. With due respect to the medical fraternity, I would like to say that since the doctors come across SMA patients very rarely, many of them do not know much about the nature of the disease or its prognosis. We are trying to create more awareness among the doctors and also share the established standard protocols for SMA to increase their understanding. We require to sensitize the media members also regarding the practical aspect of the SMA and the challenges they face in their everyday living. When the media highlights the battles of the SMA warriors and their degrading physical conditions and still are working to achieve like normal people, society will also understand better the basic reasons and may look at them with more empathy. The government agencies are also have to be created awareness for them. Since SMA is a serious, life-threatening, chronic, and progressive disorder that places substantial medical and financial burdens on the patients and their families, creating awareness among government agencies is very much necessary for building the infrastructure for better management of the disease. SMA is a complex disorder and is difficult for one organization to tackle all the issues. In these circumstances, collaborating with different organizations with common goal is helpful in building multiple resources that patients can look for support and advice in various ways. And it's also an effective strategy for changing the programs and policies. Pure SMA has grown to network with individuals, families, clinicians, government, pharma companies, and others to work together to support the affected individuals, their caregivers, and educate the public and professional communities about SMA. Lack of medical treatment and assistive technology, prohibitively high cost of treatment, Accessibility to healthcare services and awareness about SMA are the major challenges clinically. Building an effective healthcare network throughout the country to provide superior management and care for all SMA patients is of prime importance. We need to establish standard SMA protocols which can act as a resource for the doctors to improve the quality of care for the individuals with SMA. Although there is no cure for SMA, the advent of supportive inventions includes multidisciplinary care, and this has improved the treatment interventions and enhanced the quality of life for patients and their carers. Respiratory management and early treatment with non invasive ventilation have improved the outcomes of the patients. Survival benefit has become evident, and with the advent of the multidisciplinary care framework. Recognizing the significance of the multidisciplinary care, Cure SMA India, in association with major hospitals, organizes regular multi-speciality SMA clinics in few cities and plans to extend them to more cities in the future. This generally benefits all the patients of the region as they get to meet all the concerned doctors at one place. And also, it helps in regular monitoring of the children, which helps in identifying any underlying problems early. Thus, providing an accessible treatment to all is our main goal, and we are sincerely working towards it. We need to generate funds for financially needy patients from various sources like individual donors, corporates, etc. Cure SMA India supports poor patients for major surgeries, hospitalization charges, assistive equipment such as wheelchairs, braces, etc. Collaboration with the government is necessary to improve the quality of healthcare, to modify the existing policies, design new policies in favor of patients and other stakeholders, and also required to promote healthcare system that is realistic to all and not only to the rich and affluent. Disability rights are formed by the government to protect and ensure the enjoyment of human rights and fundamental freedom by all persons with disabilities. Providing information to people with disability about the human rights is very much essential to identify instances of discrimination. We also assess the members to uphold their rights by speaking and writing to the people and organizations to raise awareness about the problems and seek solutions. One example within our community I can give, many of them do not know the right that the children are eligible to go to the normal schools. Most of them are rejected and some of them sent to special schools. When they come to know that the children can go to normal schools, quite a few of them again went to the normal schools and convinced them that the child can study in the normal school, and they got admitted. So in this way, it helps them when they come to know their rights. Receiving emotional assistance is the most significant part of being a member of support group. Support groups allow people to talk about their experiences with others. This can help reduce the anxiety. Group members can share the feelings and experiences that may seem too strange or too difficult to share with the family and friends. Being a part of the group often creates a sense of belonging that helps each person feel more understood and less alone. Exchanging information and advice may provide a sense of control and reduces the feeling of helplessness. We regularly arrange regional meetings in the cities locally so that the patients and families can meet and interact with each other. Patients are able to take more informed decisions based on the advanced knowledge available combined with the experiences of the seniors. They feel more confident and are less prone to repeat the same mistakes of senior members. I would like to give an example over here regarding the scoliosis surgery. The scoliosis surgery was a difficult surgery, and many children in their teens could not get the surgery done because of various fears of their parents. Such children have a huge spinal curvature and less respiratory function. Comparatively, the few of them who got done are much better with a good posture and better lung function. The younger parents can easily see the difference between the two and take an informed decision. Most of them prefer to get the surgery done without any fear so that they can give a better quality of life to their children. In the rare disease, patient advocacy groups and drug companies are enthusiastic about partnering with each other to develop new drugs and genomics based diagnosis. In the West, we can see that many pharma companies and patient advocacy groups are bonding together to present the development of new drugs for rare diseases. Advocacy groups rely on their partners for financial and scientific support while providing access to repositories of patient data, which is the key to understanding the rare diseases as well as assistance with clinical trial and enrollment. Cure SMA India is networking with the drug companies, the government, and other concerned agencies to bring the US FDA approved drugs for SMA to our country. With the treatment available in some parts of the country, it is some parts of the world, sorry, it is really frustrating that our children are unable to get the medicine and are deteriorating day by day. There are 3 medicines available as of today, but none of them are available in our country. We hope the government understands the emergency situation and helps to bring the drug in India. According to the World Health Organization, patient empowerment is a process through which people gain greater control over decisions and actions affecting their health. Patients and caretakers feel empowered with productive discussions with the other members of the group. In Cure SMA India, the members are encouraged to share about their concerns about healthcare, about their future pregnancies, physiotherapy sessions, diet options, education, etc. And regular guidance is given by the people who know more information. This improves their awareness, which in turn reduces their anxiety and depression and results in psychological well being and superior quality of life. They also appreciate the benefit of networking with the other members and feel more confident during their difficult times that they are not alone in the struggles and the battle against SMA. Thus, being with the patient advocacy group, they can feel more in control and empowered, which allows you to focus the right amount of energy on your health and well being. The SMA ecosystem includes all the stakeholders necessary to enhance the quality of life of an SMA patient. The SMA patient, as in the diagram, you can see the SMA patient in the center, surrounded by family and friends on one side who take care of him physically and emotionally. On the other side, we see the patient advocacy group, which helps the patient with the healthcare providers and recognizing his rights as an individual in schools, workplaces, and society. The patient advocacy group also acts as an interface with the government and drug companies to facilitate affordable access to the new drugs that are available. In this way, the patient advocacy group helps in developing the SMA ecosystem, which is patient-centric with reduced barriers and improved access to holistic management and treatment of the SMA patient. Thank you for hearing me. That's all from me. Thank you. Hello? Hello? Can you hear me?
Yes, yes, we can hear you. We can hear you. We are waiting for actually. So
Thank you very much, Miss Sri Lakshmi Nalam, for sharing with us your experience and very heartwarming and inspiring moment as a mother of a SMA patient, and while leading the Parents Lead Community Organization for the Welfare of Children affected with SMA in India. We have a question for you, Madam. If you can,
Yes.
Okay, the question is
Yeah.
what kind of documentation Cure SMA India has gone through to deal with doctor and pharmaceutical in the absence of the final in India? And maybe you can share also your suggestion for a group support like in Pakistan and also SMA in Malaysia to start with planning for availability of treatment for SMA patients.
Yeah, thank you for the question. Actually, there is complete absence of funds in India, and we generate it from the individual donors, our own members, etc. And we directly network with the doctors and the pharmaceuticals, and thus we create more networking and more collaboration, and we gradually do it step by step. I think we should start for a new SMA group in Pakistan. Maybe we should start from the basic. It really took us 4 to 5 years to reach this stage. Maybe we start from the doctors who are dealing with SMA, the neurologists, the pulmonologists, orthopedicians, etc., who are willing to work with. So we generally, in all cities, try to find out the doctors in that area and network with them. We also try to connect to the people who are in the research, etc., and also to the other groups which are doing similar kind of work or which have the similar goal. So, for example, in India, we have an organization for rare diseases in India. So it is an umbrella sort of organization for all the rare diseases. So we have to be alert regarding the organizations present in our country and thus start planning from step by step.
Oh, okay.
Mm.
So, meaning that the doctor, medical doctor, also giving their um, huge function in making of this collaboration with pharmaceutical. Am I right, madam?
Yeah. Yeah, I can see the question. Actually, Professor Nalini from National Mental Health and Neuroscience Institute, I don't think she is in association with the Cure SMA India. There are many other renowned people, Dr. I.C. Verma, etc., who are associated with the Cure SMA India. Many other experts who are with the Cure SMA India.
So, Prof. Nalili is no longer with it's still with the National Mental Health.
Yeah,
Or
they are not in our collaboration actually.
okay. Okay, thank you, madam, for your sharing. And maybe we can ask you after we finish the session and the Q&A session, inshallah. Okay.
Okay, thank you.
Thank you so much. Thank you, ladies and gentlemen. Moving right along, it's now my pleasure to introduce our first speaker, Associate Professor Dr. Teguh Haryo Sasongko. He is currently the Deputy Director of the Perdana University Center of Research Excellence. He is also an Associate Professor at the Perdana University RCSI, Royal College of Surgeons in Ireland, School of Medicine. He is currently leading a national project in Cochrane, Malaysia, that aims at delivering the content of Cochrane evidence to the public. His research has been focused on the molecular genetics and therapeutic studies, a single gene disorder, complex multifactorial disorder that include diabetes, cerebral palsy, Duchenne muscular dystrophy, spinal muscular atrophy, and tuberous sclerosis complex. Okay, without further ado, please welcome Prof. Teguh with his presentation title, Cochrane as a source of quality evidence on spinal muscular atrophy. The floor is yours, Prof. Teguh.
Sorry, it took time for me to find the unmute button. Thank you, Siti. Thank you very much for your kind introduction. Can I clarify that I can be heard clearly
Yes, you can be
and the slide can be seen?
here. Yes.
All right. Thank you. Thank you very much. Okay. First, thank you, Siti and Prof. Atif, for inviting me to this event dedicated for SMA patients. I understand that there are medical doctors as well as perhaps representatives from SMA patients coming to this forum today. What I'm going to present today is something rather different in terms of how we can actually find evidence related to spinal muscular atrophy. What I'm going to present here is the Cochrane evidence. I've been working for quite some time with Cochrane as both as trainer, author, and Cochrane collaboration. So, and I think Cochrane presents a source of quality evidence, evidence that has high quality, especially for healthcare. And one of them, one of the health that we are talking today is about spinal muscular atrophy. Okay. Okay. Problem with this one is I cannot move easily. So I think I'll just do it this way. When we talk about evidence, everyone needs evidence. When we talk about evidence, it's not only about doctors, medical doctors treating their patients who need what are the best evidence for their patients. But patients and families also are keen to know what are the best available evidence related to their disorder, related to their clinical problems, and also interest groups, NGOs, uh, 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 groups within the society that will contribute to policy making done by the governments. They also need to know about evidence. And of course, healthcare providers, not only medical doctors, but also paramedics, nurses, nutritionists, and so on. And then, of course, scientists, researchers who are working in the field, for example, SMA, also need to have information in terms of the quality evidence. Every day we have been fed with so many different information coming into our WhatsApp, coming into our mailbox, coming into our knowledge. Hearsays, testimonials posted on the website of pharmaceutical companies or companies selling this and that products and so on, and also press releases done by government officials, press releases done by pharmaceutical companies, and so on. We also hear about experts' opinion, giving their ideas in their blogs, in their social media, in newspapers, and so on. But also, we also know about scientific publications. Yeah? And scientific publication, there are many different types of scientific publications. We have case reports, we have original articles, we have systematic review, and so on. So now, what is quality evidence actually? Right. It's really with in this current situation, in the current world where we are living now, where information are really everywhere. It's very easy for us to get information. The challenge for us is to actually filter the information. We cannot cope with all the information. What we can do is to filter which one is the best, which one is the most appropriate for our situation, and how we can actually internalize that, make it integral into our problems, make it relevant into our problems. What I'm going to present here is uh, uh, how the Cochrane collaboration presents itself as a source of quality evidence in especially in healthcare or in medicine. Um, yeah, the Cochrane Collaborations is a non-profit organization. It is, I would say, it is more of a scientific organization. Its mission is to promote evidence-informed health decision making. Yeah, there are two different strategies that the Cochrane is working on. One is to produce high quality and relevant evidence, yeah, in healthcare, and second is to make those evidence accessible uh, for everyone that I have mentioned earlier, because evidence is not only relevant for healthcare providers, it will also be useful for policymakers, patients and families, and so on. So we try to make it, Cochrane is trying to make it those evidence which has been produced accessible to everyone. This is not a very uh, 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 easy job to do, because if you are producing evidence and you are producing it in the way it is very scientific, then you tend to be very technical in terms of your language, in terms of the way, your style you are presenting it, and then you have to really translate it into a more relevant, a more easily digestible kind of language that are relevant for everyone. Uh, Cochrane has a strategy to 2020. This year is 2020, and Cochrane is now working on its next strategy to 2025. But as of now, Cochrane Strategy 2020 aims to put Cochrane evidence at the heart of health decision making all over the world. So we will see how it goes on so far. Um, Cochrane exists so that healthcare decisions get better. That's the idea of Cochrane. At the moment, Cochrane is a respected producer and publisher of systematic review of health and healthcare interventions. What is systematic review? Systematic review is a scientific methodology that collates all available evidence, make it make a summary of them, and then analyze the available evidence, available data, and then make a conclusion whether in terms of the efficacy and safety of particular interventions for various clinical problems. Cochrane is actually a global independent network of researchers, professionals, patients, carers, and people producing the highest quality of health information. Yeah? Um, uh, uh, those who are working in academics will be very familiar with how peer review, for example, is done. Peer review is usually done when before you publish into journals, done by experts in the field. But for Cochrane, one of the peer reviewer is actually coming from interest groups, from consumer groups, a patient or their families peer reviewing us. That's something interesting. I've never heard of it before, but I experienced that. And Cochrane is trying to be uh, free from commercial sponsorship, and we've been successful with that so far, and also other conflict of interests. As of now, just this morning I checked, Cochrane just published almost 8,000, 7,953 systematic reviews, or we can say healthcare evidence. And Cochrane maintained the so-called Central. Central is Cochrane trial register. are 1 million trials which has been registered in Central. Cochrane has a journal. Yeah? The journal names is Cochrane's Database of Systematic Review, or CDSR. This is the one of the highest cited medical journal in the world. With the most recent impact factor goes up to 7.89. And you will see that at the moment, as of now, 90% of all WHO guidelines published each year use and cite Cochrane reviews. This is what I have. In the next slide, you will see what I have mentioned earlier. This is 2018 journal impact factor, which is 7.755, and it now goes up to 7.89 in 2019. It ranks 11 out of 160 journals in medicine, general and internal medicine journal ranking. In 2018 alone, Cochrane was cited 67,607 times, which means if you calculate it, Cochrane evidence is actually cited once every few minutes. And Cochrane, as I mentioned earlier, this is a global independent network working to produce quality evidence in healthcare. This is really everywhere, but you will see here concentrations of centers of Cochrane are mostly in Europe. This is where Cochrane originated, with quite a good number in Americas and also Australia. In Asia, we had a good representations of Cochrane. We do have Cochrane Indonesia, which is based in Gajah Mada and also in Universiti Indonesia. We also have Cochrane Malaysia, based in Penang Medical College, with several Cochrane centers all around Malaysia in different universities and healthcare institutes. We used to have Cochrane Singapore, but somehow it's inactive. But we do have Cochrane Japan, South Korea, and China, who are very active. As I mentioned earlier, Cochrane is not only for experts, and then evidence are also available, mostly some extent for free for public readers. So we have Cochrane has one website here, cochrane.org. Every one of you can just try it out. And evidence which is published in Cochrane.org, they are translated into different languages. One of them is in Bahasa Malaysia. What are published in Cochrane.org are the so-called plain language summaries. So here it is. This is also another difference between Cochrane publications and other scientific publications. Normally, when scientists publish in journals, what they have to do is to publish the abstract as well as the body of the text into the journal. But for Cochrane, every Cochrane author, besides those things, every Cochrane author must provide the so-called plain language summary. So is a summary which is easily digestible by the public. These are the evidence that we publish in Cochrane.org. For this, not only that, we also translate this into different languages. And you can see here, besides in English, there's also evidence available in Bahasa Malaysia, in Dutch, in Spanish, in French, in many different other languages. And I'm going to share a video about what we are doing in Malaysia in terms of translating those languages? Taking some time. All right.
Salam sejahtera. Kami dari Cochrane, Malaysia berasa gembira dan bangga kerana
I hope this can be heard by everyone and seen clearly.
Yes, yes, Prof.
Yeah.
The video
Can
is
hear clearly.
quite okay. Can you
Okay.
just yeah.
All right.
dapat berkongsi cerita kami bersama anda semua. Hello everyone. What I've just said just now was that we at Cochrane, Malaysia are happy and proud to share our story with all of you.
Bahasa Malaysia started in 2015, right after the launching of Cochrane Malaysia. We decided to translate only the plain language summaries because we think people who are interested to explore the more detailed and technical abstracts would be ones who easily understand English. We set up a committee within Cochrane Malaysia that meets once a month to set policy and strategy. One of the committee's first tasks was to develop criteria for translators and editors. Our translators are mainly those who are working and studying in healthcare fields. We also accept those without healthcare background who have experience in caring for chronically ill patients. Our editors are mainly Malaysian Cochrane authors, although we also consider healthcare experts who are not Cochrane authors but understand evidence synthesis in healthcare. Our translators and editors works on voluntary basis. Our day-to-day operation is handled by a translation coordinator. Miss Nila is our translation coordinator.
Our volunteers come mainly from our affiliate sites in Cochrane, Malaysia, but we also offer student electives, and as part of their electives they have to do translation. We asked Sultan, now Dr. Sultan, why he volunteered.
Hi, so I found out about Cochrane when I was doing elective for my medical school. So I volunteered to do translation because Cochrane is a very good platform for the layman to understand the jargons that are currently being used by medical professionals. So it's like a bridge, and I'm contributing for the bridge to reach out the layman, because in Malaysia, pseudo-sciences and false information about medicine is always spreading everywhere.
One of our high output translator and editor is Prof. Lisa from our affiliate site at Malacca Manukau Dental College. She is repeatedly a gold awardee amongst our awards that we offer each year to our higher output translators. We asked Prof. Lisa what drives her to volunteer in this way.
I've been involved with Cochrane translation work for the past 3 years and have found it very satisfying. I think translation to Bahasa Malaysia is the best method to disseminate reliable scientific knowledge to the general public. Thank you.
Wong Chun Hun, a pharmacist, he started volunteer translation as a student. He has gone on and involved himself in the Cochrane First Aid Project, along with another of our high output translators, Tuan Haronisa. Just recently, we developed a collaboration with the Translation Department of the School of Humanities at one of our affiliate sites to look at the quality of our translations. We've found that no tool exists to assess quality of Malay translation in Malay. We're therefore jointly embarking on the development of such a tool. This is our humble story. Thank you for listening.
All right, that's what I can share with you with regards to our translation efforts. Okay, I tried to do some searching in Cochrane.org. Actually done something on spinal muscular atrophy. I found 3 entries for directly related to spinal muscular atrophy. But believe me, it's actually more than 3. I will explain later why it's more than 3. But for these three, it's very important information here, where Cochrane has actually produced. One is about physical exercise training for people with muscular atrophy. This is published in March 2019, quite recent. And then the second is medicines for spinal muscular atrophy types 2 and 3. This discuss about nusinersen, the newest drug for SMA patients. It says here that nusinersen actually improves motor function in SMA type 2 based on moderate certainty evidence, but not the other ones so far. And then the third one is another drug treatment for spinal muscular atrophy type 1, published in December 2019. This also addressed nusinersen for type 1 SMA patients. This says that intrathecal nusinersen probably prolongs ventilation-free and overall survival in infants with SMA type 1. Okay, another characteristics of Cochrane evidence is that it is updated every 2 years. So whoever authors are working on certain topic, evidence on certain topics, so that author is assigned for that work for the rest of his or her career to do the updates every 2 years. So at some point, when you see here, for example, here one, at some point, it says, for example, physical exercise training, it says it is uncertain whether combined strength and aerobic exercise training is beneficial or harmful in people with SMA type 3, as the quality of evidence is very low. This is as much as people can, as scientists can actually accumulate in terms of its evidence up to March 2009. From March 2019 until now, and then in the future, there will be more evidence coming up. So when it says uncertain, that will be for that particular point in time. So then as more evidence are accumulated, then Cochrane will continue to work on to summarize more, to analyze more evidence, to get more information on the benefit of a particular intervention. So and then Cochrane in its paper will also give advice on how better to do more research on that particular topic in order to get better certainty and better quality of evidence. So while I found only 3 in terms which is directly related to spinal muscular atrophy, actually the patient's problem in spinal muscular atrophy is not only those 3, but it's also related to, for example, breathing problems, which mucus deposition, which needs to be cleared up, and then ventilation for SMA patients, and then feeding tube, feeding for SMA patients, right? And then oops, yeah, right. And then there is also antioxidants. This is presenting evidence on amyotrophic lateral sclerosis, which has a very similar pathogenesis with SMA, which which is characterized by problems in motor neurons, and then managing symptoms in motor neuron disease in general. So while there are only actually 3 evidence which is directly related to SMA, there are actually more evidence which could be related to specific clinical problems that SMA patients might have. These five are the evidence that I can generate in quickly. But I believe if somebody dedicated some time enough to explore Cochrane evidence, out of almost 8,000, perhaps you can find a good number of relevant evidence which could be relevant to clinical problems in SMA patients. This is the same as the current problem of COVID-19, where there are probably only a handful uh, uh, systematic review produced by Cochrane, which titles COVID-19. But um, uh, Cochrane has actually published special collections on COVID-19, and many of them are not titled COVID-19, but address same clinical problems that COVID-19 patients might have. That's how we can use it. And then I have also mentioned earlier about trials that was deposited into the clinical trial register in Cochrane. I put spinal muscular atrophy in the search engine for the Cochrane Library central register. I found 190 trials working on SMA, and in 2020 itself there are 3 which was published or being done at the moment. Not only published one, but also those who are still ongoing. 2019 there are 25 and so on. Right. I think what I can share about how we can use Cochrane evidence for SMA, and perhaps if you see the available evidence related directly to Cochrane, perhaps there are things that are left that scientists have not addressed it uh, in Cochrane systematic review. One is perhaps gene therapy and other molecular strategies. Most of them were presented earlier by Dr. Dian, and also then stem cell treatment, perhaps nutritional interventions for SMA patients, and also perhaps interventions addressing non-medical outcomes, as what Prof. Zabidi earlier mentions. Communication, how different strategies, different communication strategies for a better uh, management of SMA patients, schooling for SMA patients, and so on. Okay, I think that I stop at that. Perhaps we can discuss more. Thank you very much.
Thank you. Thank you very much, Associate Professor Dr. Teguh Haryo Sasongko, for sharing with us the experience in leading a national project in Cochrane, Malaysia, and also how the Cochrane function. I saw there is a question for you, sir, from Prof. Anthony. Yeah, looking at the
Sorry,
map.
I have to stop sharing first.
Okay, looking at the map of Global Cochrane Center, there is only 2 in the whole continent of Africa, and in countries where there is a major impacts on health and life expectancy, there is no such a paucity of Cochrane Center there. So maybe you want to comment on that?
Yeah. Yes. Yes. This is from Prof. Anthony. Exactly. That's right. We I know there are only very a few Cochrane centers there in Africa. That's disappointing, really, given the problems of healthcare problems uh, in the continent. But I can assure you, at the moment, Cochrane is actually putting up a lot of efforts to uh, 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 promote Cochrane in the region. It has several initiatives that award African scientists who work on evidence synthesis from the continent. There are also other activities or and initiatives funding also channeled to the continent. We hope this will affect how African people see this uh, uh, the importance of evidence synthesis, so that we can see more of such initiatives coming from the African countries themselves.
Prof, I have a question. What's the difference between Cochrane and NCBI? Because I believe many students like myself and researcher, even the medical doctor depends on this database in their working nature. So is it free or subscribe or maybe, yeah?
Okay. Okay. There are two websites that I displayed just now. For Cochrane.org, it is completely free, and it contains the plain language summary of the evidence. Another website, which is CochraneLibrary.com, that contains the full text of each evidence, which is the full text of systematic review. One full text of a systematic review can consist of probably 50 pages or so, because it's very detailed and it's also very technical. If you are not a scientist or perhaps somebody who are really interested to know a detail of the data, you might not be very interested in that. And this is paid for the CochraneLibrary.com. This is paid. What I understand is that during this pandemic, Wiley, the publisher responsible for this, is making it free uh, for everyone. But I think it's only for the first few months during the pandemic. I think it's coming back to a paid access at the moment. So yes, for the uh, 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 plain language summary information, they are freely accessible and completely free for everyone to read. And if you think you are interested to read any of them, you can have information from Cochrane.org who are the authors, and you can easily actually send email to them to get the full text if you are interested enough to look at the detailed data of it.
Prof, there's another question
Yeah.
from Prof. Anthony. Do you think that in our lifetime we will see the end of SMA through gene therapy?
Um. Uh, right. Difficult question, Anthony. Really. But there is also another question whether, let's say now, I am a 5-year-old boy with SMA, and then we do have gene therapy itself. By 5-year-old, perhaps if I'm SMA type 1, there will be a lot of damage in terms of my muscle tissues and my nerve tissues. Will uh, gene therapy be able to actually completely overcome the problems, the damage that has been done? That is questionable. Or as Dr. Dian also have presented, and I believe also many scientists in the world also have tried this, is rather a multifaceted kind of approach that target SMA target the disease from different angle of its pathogenesis. Perhaps Dr. Dian can give more comments on this. That's it from me.
Or maybe we can save it for the last part for the Q&A because we are running out of time, Prof. Okay. Ladies and gentlemen, thank you, Prof. Teguh, for your
Yeah.
sharing.
Okay. Thank you.
Thank you
Thanks.
so much.
Thanks, Anthony, for your questions. We can chat more in the coming days, of course.
Yes, sure. Okay. Ladies and gentlemen, we have reached the peak of our webinar. we are honored to introduce our fifth speaker, Dr. Mehwish Niaz, an associate professor at the School of Allied Health Science, PMH Lahore Medical College, Lahore, Pakistan. She was also a director, academic and clinical rehabilitation, Allied Health Science, AIMS Institute of Management Science, Lahore, Pakistan, from 2019. She has 12 years of teaching, clinical and research experience in the field of physical therapy. For the past 12 years, she have combined her research activities as well as managing skill and abilities for upgrading of physical therapies in specific and her profession in general. So without further ado, please welcome Dr. Mehwish Niaz with her presentation titled Fact and Myth about the life of patient with spinal muscular atrophy.
Thank you very much. Share my views from Pakistan with all of you. Hope everyone.
Dr. Mehwish, we cannot hear you clearly.
Can you please hear me now?
Now better. Yeah, please proceed.
Okay, this will probably be better. Thank you, Suki, for a brief introduction, and also I would like to start with this.
Dr. Mehwish, can you make it a bit louder, your volume?
Okay, can you hear me now?
Yes.
Okay. So we will be talking about the facts and the myths in specifically in Pakistan. So to start with, there is really less work and very few people which are involved in working with motor neuron diseases.
Sorry, Dr. Mehwish, your voice is
not clear.
Not very clear. Can you just put your mic near to your mouth?
Hello. Now. Can you hear me now? Is that okay?
A bit louder, Dr. Mehwish.
Yes. Can you hear me now? Is that okay? My voice?
It's better now.
Okay, thank you. So we will be talking about the facts and myths in the community, especially focusing in Pakistan. So I've been working with many patients from the last 13 to 15 years and dealing with motor neuron diseases, being a physical therapist and working in collaboration with the different neurosurgeons and physicians and many other persons who are involved with patients with spinal muscular atrophy. So in that perspective, I will share some very important things with you relative to our area specifically. So let's start with that. What actually spinal muscular atrophy, is we know that spinal muscular atrophy is obviously a genetic disorder which is characterized by weakness and wasting in the muscles used for movement specifically. I'll be talking about especially with the muscular movements and how we can deal with that. So it is caused by the loss of specialized nerve cells. And the most important fact about SMA in Pakistan is there is not a lot of people who are being working here with the SMA, and also the community, and the parents and the people around the patients of SMA. They are very less. They know very less about what is SMA. So there are a general community myths which are being created with these patients. So relative to the SMA epidemiology in Pakistan, I would say there are right now 13,036 patients who were in Pakistan registered SMA. So these are the registered SMA cases, and there are many cases because there is no research or data which is specifically available in our 4 different provinces, and there is very less collaboration researches which were going on till 2017. While right now, I myself has created with my team members at the CMH Medical College a center which is for the diagnosis and also for the treatment purpose in all aspects, like a rehabilitation center, which includes the genetic perspective and also the how we will properly diagnose through genetic aspects, and then the muscular assessment, the mental assessment. We are working with the psychologist there. This is under one roof, rehabilitation center, nutritional perspective, and also then the physical therapy and the exercise perspective. So we are working as a collaborative team, as a collaboration team in which we have the medical specialists who are working with their medicines, like what sort of medicines they are, more importantly clinical trials, medications and in clinical trials, and then we are also having the groups which are working with the nutrition, what sort of nutrition is important for the SMA patients, and also the psychologists who are working with the counseling sessions with the parents as well as with the SMA patients. So, and the last, we have the clinical trials also with the physical therapy sessions, because right now, as mentioned in the Cochrane's lecture, there are very less evidences and there are very less clinical trials which are working with combination of different types of exercises and what sort of exercises which are useful in different types of SMA. So in generally, the myths in our community about the SMA. What the myth is, once the child is being diagnosed with SMA or any patient is diagnosed with SMA, the most important myth they felt is there is very shortened lifespan, and they never pay heed attention for the treatment purpose, and they never look for their future perspective. So there are so many reasons relevant to this, because like obviously some of the parents they have 3 or 4 child and they are financially not stable, and financially they are not being supported for treatment of these children, and so the counseling session to those parents, and we have separate sessions for the psychologists with the psychologist, and they are providing them the basic knowledge that this is what you have to do, this is just a myth. So generally, like we provide appropriate therapy with the physical and respiratory treatments along with nutritional support, so they may live their best life for so I think the second aspects which are working there is more important. So the second important thing which the parents with the SMA child came, they say children in the public settings, right? They think this is a useless person, and because of longevity, so they just don't pay attention to that person. But the important thing which needs to tell them is that the SMA person's mental and intellectual capacity is not compromised. Like you are not supposed to suppress that in intellectual and mental ability of that child. So if even a child is being school, So the important thing is we have to work at the national level too. So at the national level, like we are giving our options to the public schools, and public schools here they are required to have those programs to place and accommodate the special individual needs. But right now, there is a lot to be done, and also we are working with the school projects, different areas where we can put some help for those individuals at the schools, and also for the training of the teachers is also required to handle such individuals. So I think we have suggested the individualized education program as in the USA in 504, right? So we are working on that too with the government help for those individuals. Important thing of that is that we should the second important thing, the important myth is that SMA can only occur if both parents are there. So this is also they must be told because it is a recessive disease. So typically, child will only have SMA. So we must educate those individuals in our community. What so like how this disease is genetically transferred. According to Cure SMA, when two parents carriers, the child will be 25% of being unaffected, and the child has a 50% chances of becoming carrier, and the child has a 25% of the chance that they will have SMA. If only one parent is the carrier, then the child is usually not at risk. So this is very important because because of the social perspective, um, like because of the social perspective, it is very important to let the parents know how the disease is genetically transferred. So another important myth is like 95% of all the SMA carriers can be identified with simple blood draw. Like this is like we have done with the blood test, and yes, it has been diagnosed. But according to the research, which is the 5 of the ethnic groups tested in the United States show, and in different 5 ethnic groups shows, which includes Jews, Hispanics, Asians, and Asian Indians. Among African Americans, the test is only 70% effective. This is believed to be gradually increased likelihood of detectable mutations in this population too. So genetically, as mentioned, like what is needed, so there is a lot of room to be worked on these aspects and myths, and then the effects. So with diagnosis of SMA, a person's life is permanently being many. The myth is that when the patient is affected, the life is permanently altered, and there is a physical difference between. Yes, there is a physical difference, but counseling should be needed, and the truth and the fact uh, told to the patients and counseled the patients, like what are the plans from the day of diagnosis until the patient will be able to live with a full life. So it is very important to to work on the different aspects, which I have previously mentioned you. The aspects of physical aspects, the mental aspects, the social aspects, and also the financial aspects, and providing them different accessibility so that they can easily move. The most important, so like I have a case study, which I yesterday I received a patient from after diagnosis with SMA, the child was in a very low mood, depressed, and he was 8 years old. And her mother started weeping, and she was like, my child will die within a day. So and so what we will do when we don't know what aspects can be talked about. So it is important that we should find out the myths which are going on in our society, and those myths are working more strongly than the facts. So the facts should be given to our community centers and the rehabilitation centers. And I also like in comparatively, not that diagnostic center, there is only one diagnostic center, there is only one rehabilitation center which is been working with the multidisciplinary approach. So I welcome any one of you who can work with our SMA center, and we can do certain clinical trials with in nutritional, with the nutritional aspect, with the medical aspects, with the physical therapy aspects, and also with the social and mental issues with the child and also with the parents. So this is just a brief introduction, like how SMA work in Pakistan and how we are going to proceed with it and how we are dealing it. It's just a start, and I hope any one of you can join us and we can make a simple group where we can develop or coordinate in modern neuron diseases or specifically in SMA. So thank you very much for listening to me, and thank you, Siti. If any questions, can I? You are most welcome.
Dr. Mavish, can you hear me?
Yes, yes, I can hear you.
Dr. Mavish, I just want to ask you, for example, in case of the people from Pakistan, we have a big issue with we lack the physiotherapists who are very specific to SMA. We have quite few people from SMA Pakistan who are also listening to you. Is there any possibility that your unit or your department can help us to give a training to, some physiotherapists from other parts of the Pakistan?
Yes, definitely. We are providing them. Like we are having a group of individuals with different areas of Pakistan, and we are working them on the THQ and DHQ levels, and we are coordinating with them and also giving them different approaches how to deal with the SMA patients, and we are in collaboration with the data as well. So we will come to the a collective point of view to how to proceed with those patients. And I will be
Okay,
very
okay,
happy if we
okay,
can have a national, international collaborations too.
okay. Thank you, inshallah, inshallah.
Thank you very much, Dr. Marish Nias, for sharing with us your experience, especially applying physical therapy in treating the SMA patient. So now we are welcome for more question, if any, on the floor. Dr. Marish, I may like to echo what Dr. Atif asked you just now. I've learned that to know that there is a specific physiotherapy unit focusing in treating SMA patient in Pakistan. Am I right?
Yes, yes, yes.
So how when it started and how it helped the SMA community over there, and maybe we can learn from you how to start in Malaysia, because we don't have here in Malaysia. In Malaysia, physiotherapy is just general. Even some, in my case, some physiotherapists do not know what the SMA is. So they need to learn more about it before
Yes,
treating
they are
them.
most welcome. We have the full, as I mentioned, the full rehabilitation center in which we are dealing the SMA patients, not only the SMA patients, but all the patients with the motor neuron diseases. There's a separate group who is been working with those patients with their specialities like Parkinson's disease and also with the leptospirosis and also with the other motor neuron diseases. So there are journal perspectives how to deal with the motor neuron diseases, and then the special perspective for dealing with the special diseases. So you are most welcome. anyone of the group from there can visit, and then we have us collective research or group research group where we can collectively work with the two nations or any other parts of the areas. And so we should
Uh,
understand
Dr.
how we
Mavish,
could work. Yes.
Dr. Mavish, there is one question for you from Ms. Madhya Kyani. She's from US, but basically from Pakistan. She has a question. Dr. Mavish, how do you ensure that the bone density or the breakage does not occur with SMA patients?
Yes, we are continuously, especially with the SMA patients.
Yep, yep.
Yes. Okay. Obviously, the muscle, there is a risk of fall and the risk of many things which are with these patients, because I have given you an idea. The patients are, once they think about their child is with SMA, they don't care about the nutrition and nutritional guidelines, and also the other guidelines they are not being given to them, like what sort of nutrition they should have it, and what sort of the uh, psychological counseling they should be given. So we are providing with a nutritionist to them who make a full plan for the individuals, and those individuals, those SMA patients. And also we are continuously monitoring the vitamin D test through testing, regular testing. So the both and also with the medical assistance from the medical specialist. So we are always been working in collaborations, and we always have a meeting before prescribing anything to SMA patients, and we deal every individual, every SMA patients as a new patient, because obviously the values and the conditions and the testing is very difficult, very different, and the patient is also from different areas, because this is the only rehabilitation center where all the facilities are under one roof.
Okay, thank you, Dr. Marish. Is there any other question? So I think there is no. I would like to ask all of you your favor to open your cameras so that we can have a group photo. Is possible? Turn on your camera.
Oh, now photo session.
Yeah, photo session. Yes.
It's a nice photo.
So I'm welcome everybody to open your camera for photo session. Oh, okay. It's okay. Miss Mudiha, it's okay. Those who are happy to share with us. Okay, Prof. Hatif is there. Dr. Marish, can you? Hi, Miss. Hi, Dr. Marish. Okay. Dr. Dian, are you with us?
already on.
Already on.
Yeah, maybe it takes a little bit more time.
It's okay. We wait for you. Prof. Zabidi. Dr. Dian, have you opened the camera? Okay, I took once. Ismail.
Everyone should say Furra or Safura. Furra.
No, 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 no. Yes, please.
Lots of closed cameras here.
Yeah. I think Prof is too early morning actually in Pakistan,
Ah,
especially, so maybe
ah,
many of the people still laying on the beds.
yes.
It's
Yeah.
really in Pakistan. What?
Yeah, it's a bit early morning, 7, 8 a.m. I think well, I think 9 a.m. right now, but it's a weekend.
Mm.
Yes, it's 7 a.m.
Yeah,
So I think this is the
Prof
end.
Zabit is also there.
Yeah, he seems to be reclining.
And we are still waiting for Dr. Dian to open his camera. You want to do a group photo now?
Yeah. Dr. Dian, are you there?
Yeah, I'm here.
Can you switch on your cam?
Already, however, maybe we had the signal. Yes.
Roatif, are you still with us?
Yeah, luckily my power supply is back. Today during the something rare happened. There was a cut of power supply. Then I'm using my phone with the tethering and everything, so that our session will move on. So just when she asked for the picture, the power supply is back.
Oh, yeah. So I think end of our second webinar, the International Symposium on Spinal Muscular Atrophy. I'm thankful to all the speakers, guests, and participants in this event. Maybe Profati would like to some closing remarks before we end.
Sure. Actually, I would like to first thanks to Prof. Savidi, Prof. Tegu, Dr. Dhyan, Miss Sri Lakshmi, and yes, to Dr. Mavish. Actually, it was very good because some of them are my mentors, and it was always a great time to learn from them. But even the last session and even this session come up with some very good ideas. Like it's starting with a very productive session with Prof. Zabidi, in which we have a new ideology of spikeless. I think which really need to be come out to be productive as soon as possible in a form of publication or something, for the SMA community. And then the next session was with we have Dr. Dan, which come up with a lot of extensive data from Indonesia, and especially the slide I loved a lot was the documentation and the checklist, which is needed by all the other SMA groups. Which actually, we are going here and there, but that checklist was missing. It's too good for everyone to follow. And then Ms. Lakshmi coming in, and she has explained a lot what she has gone through and what are the things she has been facing as a mother and as one of the person who is helping the SMA community. But inshallah, I think we're going to have another session with Ma'am Sri Lakshmi for the purpose of, what are the documentation and what are the kind of funding issues she has been facing and how they overcome it. That's very important for the lower and low income countries, as a developing country to come up with. It's very important for us. And then we came up with my very favorite colleague and one of my favorite person, Dr. Tegu, and he taught us about Cochrane. And yes, it is too important, especially from the medicinal point of view and also from the non-medicinal point of view, in which when we in the SMA group WhatsApp, we got so many questions, which are a bit, easily could be understand if somebody is using even Cochrane.org. It's very useful. And I'm really thankful to come up with the idea of presenting Cochrane here. And then the last presentation was from Dr. Mavish, which actually the most important thing for the SMA Pakistan people here, that they did not know that there is a proper active SMA physiotherapist unit working in Pakistan. With a lot of extensive data they're already having, and we are trying to actually bring in Dr. Mavish to collaborate with other people, at least within Pakistan, and then overseas she can also help us. Actually, Prof, she did offer us to they can provide the training because CMH is Combined Military Hospital. It's the most stable hospital in Pakistan. So they have units all over the Pakistan. It's under the army of Pakistan. It's very stable. So I think they're the right people to go in, and they can help us a lot in with the SMA of the physiotherapy part. And she did mention they have a proper molecular lab for the neuromuscular disorders. That is another good advantage. So they have everything at one place actually. So we are trying to collaborate her with other people in SMA Pakistan, and we can also, inshallah, if we need help, we can ask her if needed. So it's a very productive session. Thank you so much, all of you, for being there with all the valuable time, especially during the weekend. And really owe you a lot, and we just can make dua for you. We can just make good thanks to you, inshallah. So thank you so much, all of you. And a special thanks, I forgot, for a special thanks for
Thank
always
you.
tolerating me, for always helping it out. It was not possible without her.
Thank you, Prof. Thank you, Prof.
Thank you so much. Thank you so much, all of you. Assalamu
Thank
alaikum
you.
warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi
Assalamu
wabarakatuh.
alaikum. Assalamu alaikum.
On behalf of organizing team, I thank you
Thank you,
all for
everyone.
taking time.
Thank you.
Assalamualaikum.
Bye.
Well, just for the any shortcoming, I hope wish you all pleasant day ahead. Thank you.
Inshallah. Thank you so much. Assalamu alaikum.
Bye. Bye.
Thank you very much. Bye.
Bye. Bye, Anthony.
Bye, everybody.
Bye, Prof. Bye.
Bye. Welcome. See you. Okay. Prof. Anthony.
Thank you.
Prof.
Prof.
Keep healthy.
Thank you so much, Prof. Anthony. Thank you.
See you.
So, I'm going to close the meeting now. Thank you so much, inshallah. Good luck.